is back, and we have better gadgets, better instruments to deal with thrombus, which all of us know is a real challenge in cath lab because almost 50% of what we do is in relation to STEMI interventions. It's a privilege to introduce you to Dr. Sidney Lo from the Liverpool Hospital, Sydney, Australia. He's the head of interventional cardiology and has a vast experience in managing thrombus. So, could you please tell us about the new gadgets that you have and the new trials that you're doing? Because thrombus will always be a problem for us.
It's fascinating you say that thrombectomy is back. I guess it never really went away. We're very committed. We love the concept of sucking up the thrombus and achieving flow in the artery. And I think the primary thing is flow.
Yeah.
And I think maybe we didn't do it quite as good as we should have, because in the clinical trials like TASTE and TOTAL, there's a signal to stroke. And maybe a bit sloppy with guiding catheters, maybe it flipped out into a systemic circulation. So now we're very conscious of how we do aspiration thrombectomy. And there's new devices, so the Penumbra. So now I think we definitely make sure that we have good guide support. We have maybe 7 French if we need to have devices. And we also make sure we're sucking out the guiding catheter, leave nothing behind. There was concepts like a drag and drop. So if you're doing a circumflex aspiration, maybe you drop something in the LED. That's a really terrible thing when you're having an infarct in from both circumflex and LED territories. So the new system has a continuous suction, a Penumbra system. They're using it in the brain. They're using it for pulmonary embolism aspiration, big clots. So it's like the Dyson for the coronary artery. Just suck it out of the artery, right? Not it's Hoover business. Just suck it out with continuous minus 20 millimeters of mercury suction, and much more effective. And that's part of it, I think, what we're doing.
I'm going to take you back because you witnessed the history and the change, and for your young colleagues I want them to understand it's been a journey where all of us have learned to understand thrombus, and our devices have matured over the years. And I'd love to hear your perspective right from the AngioJet to the various devices that have come and gone. So just give them a perspective of what happened, because they may not understand how we've come to this device.
Yes, I think the primary PCI concept was basically getting flow in the artery, and we used a balloon, and then we debated about leaving metallic DS or any metal in the artery, about how thrombogenic it is. And we know that that's a foreign material, but yet the scaffolds won out. I mean, having a metal stent actually improved the flow, but there's a stent thrombosis rate. And I think from our point of view, we like things to just dissolve. But we try that. It's not 100% effective. But I think sometimes what you can have, if you don't have an interventional service, in the old days, there was no service, maybe just diagnostics. And the one thing they could do is instill some fibrinolysis agent like streptokinase, urokinase, subsequently TPA. And that may work, but there's always a risk of embolization. But now the flow itself is fibrinolytic. And so conceptually, we then used a very much, I think at the time, the most efficient thrombectomy system, the AngioJet. But actually, it didn't win out. It looked like it was a very rough procedure. Patients sometimes complain of extreme pain when you're sucking out the blood out of the coronary artery. And although I have some success with it, in the clinical trials, it's pretty negative for a good impact. And so I think we largely gave up on it.
I think a lot of this, we try to generalize it, while these are niche devices. So for most of us in India who see patients who come late in the course of the disease, we see that as thrombus burdens. But in more developed countries where they have, patients coming in within a couple of hours, you wire the vessel, there's hardly any thrombus. So a routine thrombus, I don't think was, if you have to critique the trials, I think a routine thrombus may have never been a good strategy. And the niche device that it is important. And I suppose because mainline trials, put it as harm, people lost their interest, but I can tell you we've always been using it in this part of the world. And I think so. Could you just tell, to keep the interest of our young interventionists, what is the method to do a thrombus aspiration from the existing catheters? Because technique is very important.
Yes, that's right. So we suggest good guide support. And because that's a signal for stroke, we're going to make sure you don't lose guide capitalization. So stability of a guiding catheter is good. Consider French size. So the larger the mechanical manual aspiration, I think a bigger French size is slightly more helpful in thrombus aspirating ability. Then, of course, is your technique, no side hold in the guiding catheters. And of course, you have to optimize the anticoagulation. You have heparin, the ACTs, you may need to check that. And some people do use glycoprotein 2B3 antagonist during the whole thing because of the antiplatelet, and gets in the system quickly. Now, as you're aspirating, we always leave the neck of suction on the syringe so that as you take things out. Now, when you go inserting the catheter, sometimes it stops and probably you might have caught a bit hot. And so you try to aspirate that out and then don't turn off the suction, leave the syringe on negative, take it out and then aspirate the guiding catheter, even once or twice. I think that's a good technique to try to avoid it because some people are very anxious and want to inject angiogram check flow. Whenever you do that, you might send all the stuff you've aspirated in the system back in the artery.
So I think, see that it's well air-locked before you go in. And when you put the thrombectomy catheter in, please have the flush on. Don't move it because it's a bigger profile and it takes air in along with it. When the TUI burst is open, don't tie the TUI burst too tight. And proximal to the lesion, activate suction. And go very gently. It's not fast in, fast out, breathe, relax, and move it very slowly through the thrombus. And if you get it stops sucking, or just tap it, and if the thrombus stops coming, pause, get it back. So I don't know whether you do it, but a good thing is to actually lock it when you're in the proximal part of the vessel. So the suction stopped and you're not moving it from there. And again, open the TUI burst, keep the flush on and get it out, and back bleed your guide. Flush the aspiration catheter and then go back. And if you even have the need to give any of the vasodilators through that catheter, get it back with a good back flush and your flush on from the side, and then go back. Because if you keep the suction on and your TUI is open, it's going to keep sucking in air. And in that panic, you may end up throwing air. So be very careful about, they don't like to stroke if you've already shut the suction before you come into the guide. Just in the proximal vessels, you put off the suction and come back. So the catheters are not bad, but if you know the only problem was stroke, then keeping the guide aligned, having a good size to it. And if you hit suction, hit resistance, come back and go back again. I think that's reasonable. You shouldn't really have a trouble with it. And I think very important, you raise the point of a 2B3A. See, a very sick patient may not have absorbed the ticagrelor that you've given. And it's a good habit, it may not be a bad habit, to give underdose abciximab intracoronary because it works extremely well in this high thrombus burden. And the key to giving abciximab would end up being heparin. So, you don't overdo the heparin. So try to stay at 70 units per kg. And if your ACTs aren't too bad, that underdose abciximab is not really going to give a problem. And then the revival of the lytics that you were mentioning to us, if you could tell us.
Well, I think that once you establish flow, and then of course you have to do an angiogram to see there's some flow. It may be a decision not to stent at the time.
Very good. Very important. Very important. I see you must take the word he's saying. Every word is very important. Flow is the best lytic. So if you get a trickle of flow and you can see the distal vessel, you must know at what point you're going to stop and not keep squeezing the stuff down into the microcirculation, which is inflamed and edematous, and you have to respect the downstream circulation. So that's it.
And often when you do, in some of these situations, you do stent, try not to be too aggressive about post-dilatation because that also can cause cystoembolization.
Very important. In a STEMI, you typically undersize. So if you think it's a 3, go 3.5, go to low pressure, try to get the edges and do it like we did vein graft interventions. A little longer than the edges, go up slowly, inflate the edges, trap the thrombus back, hold it to nominal pressure, come down slowly, stay at that 1 atmosphere, and always pre-treat the vessel before instrumenting it. So give your vasodilators down before you really, treat it.
Because you're pushing it in so much thrombus. Is definitely a bit more in this situation for stenting.
Correct.
If you do end up stenting those vessels.
So if you could tell them, we had this concept of this M-guard stent that's also come and gone, because it's just not trapping the thrombus. If you could tell us about that.
Yes, we tried it many times. And of course, if you do get aggressive with it, it has a mesh. And so it can still cause no reflow. It can also still cause problems on either side. And so it didn't really perform as well. Plus, at the time, it was bare metal, it didn't have a drug mesh, and people did have restenosis with that as well. So I think overall, once you get flow, I think the reason flow is so important is a microcirculation. And we're studying that now.
So it is not just the push, and it's not just a contractile pump, but it's a microcirculation that allows the circulation to come. And I think we're just looking at the whole circulatory system very differently today.
Yes.
And we have to learn to see what we don't see. We have to feel it. And intuitively, when you're working in the lab, don't doubt your intuition. I think you understand microcirculation better than what you see. So tell us more about the new device, because there have been limitations of the thrombus aspiration catheter, and the Penumbra has been used for, intracranial vessels also.
Yes.
And it comes with some advantages. So please tell us more, because I don't think we've used much of it in our sitting.
Yes. So I think, look, it's very small. It's an 6 French guiding catheter. You can actually, it's 6 French compatible. It has a continuous negative suction on the system. So as I say, it's like a vacuum cleaner, and they basically can aspirate. The aspirating ability, at least in clinical trials, is very highly efficient.
Yeah.
But I guess if you have massive thrombus, I don't know how organized the thrombus is. And maybe some patients, maybe the effectiveness is not so, maybe attenuated. Yeah. But we find that it is very useful. And because of the costs where we are, we're limiting that for manual aspiration failure, because obviously much cheaper to do regular catheters, and we use thrombusters a lot. And so if it's successful, you don't really need it. But if you have the aspirate, but if it wasn't working, then we reach for Penumbra.
So I think we could put the vessels into two groups. So one are the ectatic vessels, which don't do so well. So what is the size of the vessel in which we could use the Penumbra?
Well, any size, actually. But I think the problem is that it's established thrombus, the ability for it to actually get around and suck it may be poor. In which case, I think added pharmacology may be very useful in this situation.
So in fact, for a very ectatic vessel, my understanding would be in the smaller vessels, which are more platelet-rich, Abciximab works.
Yes.
But in the more ectatic vessels with, chronic, organized, fibrin-rich thrombus, maybe it's a case for, low-dose Lytic. And urokinase got withdrawn from most of Europe for more, manufacturing problems, not that it wasn't a good drug. We still get urokinase on our shelves.
Right.
So do you think it would be worth, because they become cost effective in our setting, and they come in smaller units, because the bigger vials get wasted when we are giving them you need smaller doses of TPA, Tenecteplase, and you give it intracordial.
That's right. We're studying Tenecteplase and microcirculation about a third of the weight-based dose. But people have used lower doses of TPA, whatever you have, which are fibrinolytic. And I find that actually, even in Australia, we don't really have Abciximab anymore. And a trial like Infuse AMI was using a delivery balloon and given local intralesional delivery of Abciximab with a good size reduction. In fact, we never really ascribed to that practice, because I think we're very keen on aspirating, achieving good results. And so that really never came in. I'm not sure about India, but I've actually infused Repro Abciximab in the arteries. Maybe
so we did actually. Abciximab, we've had the privilege of being the way back in 98, 97, 98, studying it very extensively. And of course, we were a lot of times underdosing and getting very good results, because that was the time when we had ticlopidine. We didn't even have clopidogrel at that time, and it did allow us to do a complexity of work which we were not doing before that. So, and we're fortunate we still have it. I think it's all about understanding maybe you have more cantilol, but for cost-wise, these older drugs which we understand become better. I think the most important thing that he said is flow. So in our young patients, where we see a very high thrombus burden, as long as we have a flow, we should not rush to stent, and we can always come back, because 4 days later, you may have nothing to stent. And it's very rewarding. I think the joy of leaving a young patient without stent is more than that of doing a stent-based angioplasty and having them grow up without the need for regular antiplatelets. So I think we've covered the new devices. We've covered the Lytic. We have covered 2B3A and your heparin dosing. And I think that's it. So good luck to all of you in your work. And I hope our feedbacks and our way of working helps you to, work on your cases better. And don't panic. I think you can just relax and think before you work. Any words you'd like to say as we sign off?
I think go with the flows.
Go with the flow. Very much.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.